So we will go ahead and get started. I want to welcome Kate and Julie. We're so glad to have you all back and get information from the veterans system. We know last year we had you all on and we got to hear a little bit about the great work that you're doing through the VA across Arkansas. And so it's great to have you back and get an update and really hear because the veterans is such an important population, and it's important we have information, we know it's happening, we're able to connect with resources. So I am going to officially introduce you by reading your bios. But before I do that, I just want to remind everyone that this is a recorded webinar. So by staying on today's call, you are giving us your permission to be recorded. These recordings are posted to the ABIN website under the webinar tab at the top. So anytime you hear something at a webinar and you think, wow, I'm interested, or I'd like to send my team that's really good information, those are available to you as a resource, and we would love you to access those. All right. And just a quick reminder, in September, we will have Verna Little, and she will be the September speaker. She will be speaking on COCM, a COCM topic, I think clinical pathways. So we're really excited to have Verna back. She does a lot of work in the COCM space, and she's been on these calls before. So with that, we have Kate Rames, and she is an LCSW and the Suicide Prevention Coordinator at the Veterans Healthcare System of the Ozarks. Kate obtained her Master of Social Work with a focus on aging from the Silberman School of Social Work at Hunter College in New York City in 2012. Throughout her career, she has worked primarily in hospital and medical settings, providing clinical case management and brief behavioral health interventions to older adults and those supporting their care. Prior to joining the VA, Kate worked as a therapist at a local community mental health agency in Northwest Arkansas, where she provided individual and group therapies to clients with serious mental illness. Kate is passionate about increasing knowledge and awareness of suicide prevention strategies among veterans and with the community at large. And then we also have Julie Batson with us. Julie is also an LCSW, and she is a community engagement partnership coordinator. Julie has been a clinical social worker for over 20 years, and she has been with the VA for 15 years. Her first 13 years as a trauma-focused therapist, providing individual, group, and family therapy to veterans and their families. Julie's currently the Community Engagement and Partnership Coordinator for Suicide Prevention, where she works in the community to identify, engage, and support coalitions of stakeholders and agencies who want to help prevent veteran suicide. Julie resides in Springfield, Missouri with her husband, who's a combat veteran, and their 5 rescue dogs. Oh, 5. Wow, that's a lot, Julie. That's great.
Yeah, we're overachievers in that arena.
Overachievers in the rescue dog area. I love it.
Yeah.
Well, with that, we're going to turn it over to Kate and Julie to hear more from them about the work they're doing throughout the VA system.
Great.
Thank you. I am just going to go over our VA Save training that we have, and with a little bit of information that I pulled together for you guys. Let me just be that person and ask you if you can see my screen. Can you all
Yes,
see
we
that
can.
okay? Okay.
Yes.
Looks good.
Don't mind me. Okay. Okay. And then, sorry, I am going to be, let me be that person just for a minute. Okay, here we go. So this is our VA Save training. So this is a suicide prevention training that suicide prevention coordinators and CEPCs, such as Julie, can, we do this, A, for all of our new staff at VA, and B, we do this out in the community. So where we are working with, colleagues, veterans groups, I always say kind of mostly whoever will have us, I'm happy to kind of come and do a training, a SAVE training. And so before we begin, we are going to be talking about suicide today. And I've been, doing this work long enough just to know that this has touched all of us on this meeting in some way. If at any point, if you need to take a break or step out, please do so. Take care of yourself. Any immediate resources, the National Suicide Prevention Line is 988, and the Veterans Service Member and Veterans Crisis Line is 988. Press 1. So our hope today, it always does that there. We're just going to provide a general understanding of the scope of veteran suicide within the U.S., know how to identify a veteran who may be at risk for suicide, and what to do, right? And the purpose kind of in us reaching out to our community providers, I always like to think about it as kind of like demystifying the VA a little bit. I know when I was working outside of the VA, trying to reach out to someone within always felt really hard to do. And I was kind of always left, what's the right number to call? So what I'm going to do today is I will share with Jenny a list, at least for VHSO. So we cover in Arkansas, we cover like down to River Valley, all of Northwest Arkansas, then like over to Harrison. And I'm going to provide a list of our clinic numbers, so for our direct clinic numbers for mental health, as well as some other helpful phone numbers for y'all to have. We also, want to work with our community partners serving veterans, as many veterans don't get care through VA for a variety of reasons. So we're going to go over some facts about suicide in the veteran population. I think we know, suicide is a national issue with rising rates of suicide in the general population. And those rates are higher and rising faster among our veterans. And, these losses affect our communities, right? So for every death by suicide, approximately 135 individuals are affected. And when we think about suicide, I think it's important just to really highlight there is no single cause. This is a complex issue. And there's an interaction of risk factors, protective factors that are happening for people, at their own personal level, within their communities. Even when we think about national policies or state policies, really kind of like that macro view of and how they can affect us, right? Kind of trickling down. So there's a whole host of reasons, that when we look at suicide. So when we're looking at preventing veteran suicide, we really want to kind of maximize our protective factors and reduce our risk factors at all levels throughout communities nationwide. And I always, that's a really tall order. And so we can't do that alone, right, at VA. So again, just kind of highlighting why it's so important that we're reaching out to you all today, right, and having this conversation, because this really does take all of us, and all of us really do have a role to play. So I wanted to kind of highlight, I was looking through, and you can look up the full report online, the VHA annual report on suicide prevention. So the 2023 report that came out, I just pulled some stuff that may be more kind of specific to this group. So when we're looking at suicide prevention in medical settings, I really want to highlight, so nearly 40% of veterans who died by suicide in the last year that we had data for, so there's a 2-year lag, so this is 2021, had no mental health or substance use disorder diagnoses. So I think when we think about suicide, a lot of times the conception or misconception is that this is really affecting our folks who will have a mental health diagnosis or a substance use disorder diagnosis, right? But yeah, nearly 40% of all of those veterans who did die by suicide had neither on their charts. So other medical conditions are also associated with a higher risk for suicide. Chronic pain, cancer, insomnia, I worked at a movement disorder clinic and a memory clinic before coming here, and a diagnosis of dementia, a diagnosis of Parkinson's. People often made statements to me that that was going to really increase their risk, and that was something they were thinking. They're thinking about suicide if they receive that diagnosis. So what you all can do, check in with veterans who are struggling with medical conditions, especially if we have a newly diagnosed condition. And we want to encourage connection to additional methods of support. If they can get care through VA, we have a host of services. We have a whole health program. We have mobile apps, online tools. We also want to really talk about secure firearm storage with patients. And you all, and Julie's going to talk a little bit more about this later, but really looking at, to training yourself on how am I talking about lethal means safety and secure storage? How comfortable am I having that discussion, and how can I make sure that I'm including that in my work? Promote gun lock distribution in clinic waiting rooms. So at VHSO, veterans can walk up to or call in to primary care mental health and say, hey, I need, fill in the blank amount of gun locks sent to my home. And suicide prevention coordinators and CEPCs are at all VAs, kind of hold gun locks and can distribute those. And so whether you're in the VHSO catchment area or the Little Rock, you will have folks to reach out to who can give you that information. So looking here, just kind of operationalizing a little bit about, what is a risk and protective factor. So, if someone's come into me and I know that they have a history of a suicide attempt, that's something I'm keeping in mind, right? And kind of formulating how I'm assessing risk. Relationship issues. So relationship issues, and also if there's presence of intimate partner violence going on for this person, those are strongly related when we look at suicide risk. We work really closely with our intimate partner violence assistance program social worker here at VHSO because that link is so strong. Access to lethal means, another big one. So we can have all of these, and these aren't wholly predictive, right? So maybe I do have a substance abuse issue, but my sense of spirituality is really strong, or I feel really, I know my family supports me, I feel really connected. So these things can kind of offset. I often think about it almost as bubble wrap around us. And so access to lethal means is a risk factor, right? And when we look at lethal means involved in suicide deaths from our latest report, the 72% of veteran suicides were by firearm in 2021, compared with it was 52% for non-veteran population. So we know that if a veteran is at risk of suicide, statistically, more likely they are using a firearm as means. So I always think about this as one of my why slides. These can be hard conversations, but this is why we're talking about it. And this is, why we need to move past kind of this information, and the reason we're having these conversations is more important than any of our own discomfort, right? So we also do know that veteran firearm owners store at least, 1 in 3 veteran firearm owners store at least one firearm unlocked and loaded. And we've also seen an increase in firearm suicide rate among veteran women. It was 281.1% higher than non-veteran women in 2021. And there was a 14.7 increase in veteran women firearm suicide deaths from 2001 to 2021. So when we talk about lethal means safety, it's really putting time and space between a person who's having thoughts of suicide and a suicide method. When we're having these conversations, we want to be collaborative, meet the person where they're at, and really have a conversation. And that is something that I think will get us a bit farther, in those discussions. The reason we're having these, again, another good kind of why slide as I think about these. So we know that most suicide crises are brief from decision to action. So time from me being like, I'm going to kill myself and reaching for my method, right? Or putting something and implementing that thought. For 24% of suicide attempt survivors, that's less than 5 minutes. 48% less than 20 minutes, and 71% less than an hour. So if we're having these conversations ahead of time, we can hopefully, if we can give someone 30 to 60 minutes, we may be able to, save their life. One thing we talk about with the gun locks is like freeze the keys. It's like putting the keys in a shallow dish of water that you can't microwave, putting it in the freezer. Usually, what we're hoping for there is by the time, as they're waiting for that to thaw out, oh, I have a safety plan. I can call my best friend, or, oh yeah, I'm supposed to see my daughter tomorrow, and I was really looking forward to that. So kind of giving someone time to move through that crisis moment and remember their resources. And we know that 85 to 90% of the time, a suicide attempt with a firearm is lethal. So that is not to minimize that 5% fatality of all other methods combined. I will absolutely, it doesn't mean I'm not safety planning around medicine, ligatures, any other method that veteran has identified. Again, this is really just to kind of help illustrate why you do see a lot of information about this topic, and why we always, we do ask about access to firearms. So we know that about 90% of people who survive a suicide attempt do not go on to die by suicide. So really just kind of underscoring the importance of talking with folks ahead of time to help them survive a suicidal crisis, because then we've likely prevented suicide for the rest of their life. I'm going to go over steps of VA Save here. And first, I did just want to touch on screening for history of military service. So a lot of times on intake forms, those, are you a veteran might be a question. And I always like to just kind of highlight, especially with, audiences such as these today, not everyone who's been enlisted in the armed forces identifies as a veteran. I always share, my father-in-law served during Vietnam, and he worked doing some, different duties in Germany. And I asked him about this. Like, so, I was like, hey, Dad, do you identify as a veteran? And he was like, and it was an interesting reaction, right? He was kind of hemming and hawing. He's like, well, I didn't go over. I wasn't in Vietnam. I didn't fight. I don't know. I did my service. And so I share that just to illustrate that we want to kind of be mindful of people's unique experiences, right? And kind of open the door to having a conversation. And so since for some folks that word can be weighted, we just can say, hey, have you ever served in the military, versus are you a veteran? When we ask, just like I was telling you about some of those nonverbal cues, we can pay attention to that. We want to be respectful, show curiosity and empathy, and be aware that, us being responsive and have an effective follow-up care, like that's really critical to building rapport. So and this is from, I think I have the link in the notes section. So New Hampshire actually has this amazing website about Ask the Question, and it's about screening for military service. And so they had kind of put forth putting on your screening, have you or a family member ever served in the military, to their intake, enrollment, or health history forms, because sometimes if someone has, the experience of being the spouse of a service member or veteran, that comes with its own considerations as well. So this really allows for kind of more informed treatment and care planning, and the ability to really identify like what are the optimal resources and referrals we can give. So I'm just going to go through here the steps of VA Save. So we'll go through each letter here. So looking at S for signs of suicidal thinking, we want to notice if someone's talking about, feeling hopeless, Something I've heard so often is when I talk with folks who have survived a suicide attempt or were in crisis, I felt stuck. I felt trapped. I've heard that many times, feeling like there's no way out. If you're noticing or they're sharing, engaging in risky activities without thinking. I had a veteran once who was like engaging in some behaviors like, yeah, I was working under my car this weekend and I didn't really make sure it was that secured, as I was under it. Or there was an 18-wheeler that came into my lane and I didn't really move over right away, kind of waited to, until they self-corrected. So these kinds of behaviors, right? Increase in alcohol or drug use, isolation, feeling like there's no reason to live, feeling like they're a burden. So obviously we want to kind of really seek immediate help or kind of immediate intervention if someone is actively thinking about hurting or killing themselves, looking for ways to die. So whether that's seeking means in their home, Googling things, talking about death, dying, or suicide, or really self-destructive or risk-taking behavior if it involves drugs, alcohols, or weapons. So say we have identified some of these signs, and then also I think a lot of us, right, in our work, we can kind of take that 10,000-foot view and look at our risk and protective factors as we're kind of making an assessment here. And we really need to check in about suicidal thinking, right? So we want to ask the question, are you thinking about killing yourself? Are you thinking about suicide? And the reason that we're going to be so direct is that we want to be on the same page. And I have done this training in different settings across, levels of, the audiences. Some folks, despite how many years they've been in the field or whatnot, this can still be an anxiety-provoking question to ask. But again, I share with you, it's so important to be direct, because if we say something like, are you thinking about hurting yourself or self-harm? And we're doing that to kind of appease our own anxiety. We're really doing a disservice to the person in front of us. And I used to feel that way, which is why I feel like it's not lost on me that this is my job now. And I'm the perfect poster child for this, right? So I used to get kind of anxious earlier on asking the question. And I was able, one day I was with a client and I asked them that. And are you thinking about hurting yourself? And he said to me, well, I'm in pain all the time. I'm always hurting. It's not going to hurt. And what he was sharing with me, and I'm so thankful he did, was that he was thinking about killing himself because of his pain. I had asked the wrong question, but luckily he was able to, tell me what was going on. He didn't let that be a barrier to sharing with me, but I had put something up there. Some people, engage in non-suicidal self-harm, right, as part of maybe a maladaptive kind of coping skill. So if someone might cut their arm, but not with the intent to suicide, and that's self-harming, and that's part of their experience with their mental health, right? So if I'm asking them, are you thinking about self-harm, that's going to mean something different to them. I don't want to hang up the phone or have someone walk out the door without knowing I was on the same page. So that's why we're going to ask directly. We're going to ask when we've identified risk factors, right? A new diagnosis, like we were saying before, and we want to ask in a way that's without judgment, and as if, we don't want to ask as though we're looking for a no, right? You aren't thinking of killing yourself, are you? That's not you, right? I'm basically communicating there like, man, really hoping you're saying no to this question. Because that's just there's so much stigma and vulnerability to around, like if someone were to share this with you, we need to make sure we're communicating to them that we're safe. We don't want to wait until someone's about halfway out the door, let it kind of go with the conversation and use their words, right? And let them know that you're listening. Mr. Smith, you're sharing with me that you're losing your housing and you're really struggling with your health. Any one of those things is a lot. And sometimes people dealing with those that kind of stress have thoughts of suicide? You know, are you thinking about killing yourself? So kind of letting him know you wouldn't be alone in this experience, right? If that was coming up for you. We want to be validating. Again, we're not here to pass judgment on the situation. We know that it's serious, right? Whatever that situation is for them. And reassure them that, you know, help is available. And so when we are talking about like encouraging treatment and getting help, so a lot of times, sorry, I was looking here. I have this slide that I hadn't. We want to make sure that, yeah, they know that resources are available, kind of address the stigma, do your own assessment, right? If we feel like this person needs a higher level of care, doing a safety plan with them. And I know a lot of y'all are co-located in clinics, so kind of following your procedure too. And making sure that folks have the Veterans Crisis Line. So we want to remain calm when we're talking with someone who's at risk. Act with confidence, limit questions, let them do the talking, and be honest. You know, so often we're not going to be able, I know as social workers, I wish I had a magic wand, and sometimes people think I do, and we don't, right? We're not going to be able to fix a lot of this stuff overnight, but help is available, right? There are people who want to walk this journey with them. Use open body language and just try to, you know, remain calm. So even if you are, and it would be totally normal if you were really anxious or you were feeling stress, try to kind of keep that in check and check in with your supervisor or colleagues afterwards to debrief and get some support. So I'm going to just take 2 minutes here just to kind of highlight the Veterans Crisis Line. So it's a 988-press-1. They also have chat on their website and a text, 838-255. You can go on. So if someone's in the office with you and they're like, you know, I think I qualify for a service connection. I'm not sure. I think I need to, you know, go to my local clinic. I don't know where it is. You can go on the veteranscrisisline.net/resource locator, and you can use that to kind of find different things right there. So we don't expect you to have all of the answers or, you know, directions for folks or instructions for folks if they're needing VA care or wanting to connect. You just need to know the next right number. And there's no wrong way to access care. So a veteran can walk into a clinic, talk to an eligibility specialist. They can call the eligibility line. They can call through the Veterans Crisis Line. And what they'll do is probably give a consult to us. It's one of the things, or hats that we wear, get the consults through the crisis line. And we'll try to reach that veteran over 3 business days and get them where they need to go. So that's another thing that we do. I also wanted to share this resource. So for those of us, you know, who have lost someone to suicide, especially, you know, as a provider or within community or the workplace, there is a resource for what we call postvention. So providing support to survivors of suicide loss. And they say postvention is prevention. Experiencing a suicide loss can put us more at risk. So this is through VA. It's a great resource and something that I wanted to share for y'all. And it's really for anyone working with veterans. And this is another resource that I wanted to make sure to share. This is the Tragedy Assistance Program for survivors. So if you are working with someone who has lost a service member or a veteran to suicide, they have a great 24/7 line. They also have a chat on their website. They have peer supports who've also walked that path and can connect with you. And I give this to a lot of our veterans. So a lot of our veterans have lost, you know, battle buddies, folks that they were in a unit with to suicide. And this can be a really meaningful connection for them. I've reached out to them when I've lost someone I was working with, and I'll just put in a plug. They're really supportive, and I would really encourage you to connect with them if that's something you're needing. This is Make the Connection, which is really helpful too for veterans who may feel, and I think many do, really isolated or kind of alone in their experience. And this really has just hundreds of videos of veterans and caregivers as well, kind of talking about their journey with overcoming mental health challenges. And since we last talked, VA has a new safety plan app. So you can share this with someone in office with you. They can put this in their phone and they can kind of have that with them. It mirrors the one that we use, and the design interface is really, really cool, pretty easy to use. And that's something that I wanted to share with y'all as well. And my last resource here, PsychArmor Institute is a free education resource. You can do the SAVE training. Again, this takes 25 minutes. And they also have so many other videos and, little classes on working with service members and veterans. So kind of getting a little bit more kind of cultural competency courses if this is a newer population for you, or a population you don't work with very often. And that is the end. No, I just kind of ran through that, but I'm just, why don't, I'm gonna kind of punt to Julie, and if sometime after we can get some questions, if that sounds okay.
Okay, great. Thanks, Kate. If we're going to kind of wait to the end to do some questions, I was going to ask if anybody had any questions, but I can just jump right in.
Oh, I'm okay. Yeah, I just want to make sure you have full time because I'm excited to hear you talk.
No, yeah, that's great. And some of the slides you used, I was like, hey, wait, that was a slide I was going to use. That's fine. No, there's plenty of information to go around. That's for sure. So I wanted to just kind of start out by talking a little bit about upstream prevention, which is what the program or the job that I'm doing right now is all about. It's all about a public health model and preventing veteran suicide. So what the VA has learned is that we can't do it on our own at all. We have to have connections with our community partners. And this is really the only way to bridge those gaps for veterans, that many who don't even seek any health care from the VA, but they're seeking health care within their community. So we really want to develop those relationships to help prevent veteran suicide. And I'm going to share my screen and show you guys a brief video that talks about, it uses this really great metaphor about what upstream prevention looks like. I hope I'm able to do this correctly. What's happening? This one right here. What are you guys seeing? Are you seeing anything?
Yes,
See a black screen. Looks like a YouTube screen. You're trying to maybe play a video.
Yes. Okay. Good. Because all I'm seeing is the Zoom words. Okay.
Imagine a
Here we go.
warm, sunny afternoon. Suddenly, you spot someone in the river being swept downstream and struggling to stay afloat. Without hesitation, you jump into the river and help the person to shore. As you help that person dry off, you hear another cry for help. Someone else is being swept downstream. Immediately, you jump into the water again and pull out this second person. This scenario continues all afternoon. As you pull someone safely to land, you have to jump back in and save someone else. Finally, you say, I can't go on like this, and walk upstream to see what's happening. As you walk upstream, you warn other bystanders. People are falling in the river. Please help them. Tell everyone you know. Finally, you find the problem. You notice a large hole in a bridge which is causing people to fall in. Something must be done. First, you put up a sign to warn others about the hole in the bridge. You warn anyone you see about the hole and ask them to help spread the word of caution. You even start offering classes to help people in the community learn how to swim, just in case they do fall in. Finally, you realize that to truly minimize the problem, you have to repair the bridge. You work with others in the community to close the hole. Occasionally, some people still fall in, but there are far fewer people that need to be saved.
Okay, so let's see. How do I do this? Oh, here we go. So that that small video, short video, gives a really good kind of overview of upstream prevention. And I really like the metaphor of it because people keep falling in the river. People are exhausting themselves with basically with crisis intervention. And so with my job, what CEPCs do is we work upstream to build, basically to repair bridges and to build more bridges in order to provide more protective factors for veterans in the community. I am going to try and find another, some of these other slides are on my other screen. Hang on. Here we go. I've got too many screens going on here, folks. Just bear with me. So while Kate already went over the statistics, so I'm not going to go over those high-level statistics with you all. But what I wanted to sorry, I'm not very tech savvy right now, you guys.
Don't worry, Julie. We have all been there.
Like, why am I having a hard time showing my screen? Where did it go?
And what I realized is it's great until I get in front of an audience, and then sometimes it gets a little clunky. So we're patient. We appreciate you taking a moment.
Hang on, I'll get it figured out. All right. Do you see the screen now?
Yes, and it is in presenter's view because we could see your slides on the side as well. If that doesn't bother you, that's fine with us.
Yeah, it doesn't matter. You can see the sides on the side. That's fine. I'm not going to go through every single one of these. We don't have time. But I just wanted to go over kind of the key, action items that we're working on in the CEPC community, which is all about building community coalitions. And a coalition basically can be anybody in the community who has, who wants to help prevent veteran suicide. I mean, it can be a coffee shop owner, it can be a mental health agency, it can be, the DMV. So these are folks that are like, yeah, we want to work to prevent veteran suicide. So the main things that we're working on is promoting secure firearm storage, continue expansion of accessible crisis intervention services, implement sustained community collaborations that focus on community specific veteran suicide plans, and tailoring these services to the needs, issues, and resources that are unique to veteran populations, and advance suicide prevention meaningfully into non-clinical support and intervention services, including financial, occupational, legal, and social domains, and increase access to and utilization of mental health services across, a full continuum of care, and integrate suicide prevention within medical settings to reach all veterans. This is a lot. I mean, when you think about, what this slide is saying, I mean, it's a lot. It's definitely not something that's going to happen overnight. But so the public health strategy is community-based, clinically based, and then this equals a full public health model. And so the key tenets: suicide's preventable, suicide prevention requires a public health approach, combining clinical and community-based approaches, and everyone has a role to play in suicide prevention. So kind of what does that look like? So I'm going to actually skip this slide. So we talk about how suicide prevention is everyone's business, not just the VAs, not just therapists, and not just hospitals, but what we want to do is increase impact, for suicide prevention. So it might be, let me give you an example. Something like a coalition might decide to do is they might decide to focus on creating connections and building connections for veterans, because one of the biggest risk factors for veterans with regards to suicide is isolation and loneliness. So let's say a coalition says, let's start a coffee group. Let's start a coffee group of veterans where they meet once a month. And maybe we bring a speaker in, or maybe we just sit and chat and just check in with each other. And that's considered a community-based, intervention. Other interventions might include, a distribution of gun locks and 988 cards. Let's say the coalition would like to do that at various gun stores and pawn shops, to where people who come in and purchase firearms, they also get a free gun lock, a gun lock packet with 988 card in there as well. So the focus priority areas is a unifying model. So the priority areas that are of focus within these coalitions, they can choose all three of these if they would like to focus on, or they can choose just one. So identifying service members, veterans, and their families and screen for suicide risk, such as Kate was talking about, have you ever served in the military? Has anyone in your family served in the military? And then promote connectedness and improve care transitions. This can be, like I had mentioned before, starting a coffee group, or there's another VFW in Joplin that they have a group they started called Buddy Check 22, and they check on each other. They call every member every month to check in, and then on the 22nd of each month they have a meeting, because they lost one of their members earlier this year to suicide. And then the third one is increased lethal means safety and safety planning, which is Kate really emphasized in her presentation, that if we, this is upstream, looking at how can we predict, what's going to happen, predict, prepare, and plan with a veteran who is at risk of a suicide attempt. What we want to do is we want to decrease that lethality as much as possible. And one way of doing that is by asking also, how do you secure your firearms? And this is kind of a hot topic in this area, because most people own firearms and most people get pretty touchy about asking, if you ask them, you know, do you have any guns or how many firearms do you have in your home? A lot of people don't want to answer that. And that's been my experience when I was working as a clinician. A lot of my clients would say, why do you want to know? I mean, what's the reason for that? And I would, of course, explain to them that that's about just safety for themselves and their children. So another question to ask them would be just bypassing the whole, do you own a firearm or how many firearms do you own, is bypassing that and going straight to just assuming they have a firearm and asking them, hey, how do you secure your firearms? And if they don't have any, they'll say, oh, well, I don't have any. Oh, okay. Or they'll say, well, I keep a loaded handgun next to my bedside table. Okay, so that opens up the conversation. Well, let's talk about safety and safely securing your firearm and why that's important. Or they may say, well, they're all locked in a gun safe, which obviously would be ideal. I'm gonna move on to this next slide. I feel like, can you guys, I don't know if you guys can see it.
We see focused priority areas across CBI SP unifying model.
Do you see the secure storage? Why do I have such a hard time with this? There.
No.
Okay. There we go. I'll do it this way. Okay, do you see the screen now?
Yes.
Great. So one of the things that the VA has put out are brochures and guides regarding talking about suicide prevention, and then also talking about secure storage to reduce suicide risk. And we have these brochures. This is a trifold one that is 2 pages. So this goes over just kind of the same kind of questions that Kate was just talking about. And then also talks about, you know, the statistics regarding firearms. You know, individuals who use a firearm for a suicide attempt, 90% of them die. So least secure, loaded in the house, more secure, unloaded, you know, stored firearm locked with a cable lock, or legally stored firearm or ammunition outside of the house with a trusted family member or friend, or legally, you know, obviously most secure is not having a firearm in the home. People who have firearms in their home are 5 times more likely to die by suicide. And also one of the really shocking things, statistic, is that the leading cause of death for children in the United States right now is by firearm. Now that's inclusive of accidents, in-home violence, you know, homicide, that type of thing, but still it's quite shocking. So this is a really good touchstone to use when talking, you know, with clients. And this is something that we distribute to agencies and to community stakeholders, or anybody really who is interested in preventing veteran suicide and wants more information on how do we talk about this? How do we talk about, you know, reducing lethality and getting firearms locked and stored safely? And I have several of these brochures. And if you all are interested in these, I can send them to you in a PDF if you would like. And you can print them out yourself. And then I can also send the kind of the more fancy trifold glossy brochures if you'd like. And I know I'm rushing through this, but I just really want to leave time for discussion and questions. So I will stop there.
And Julie, I put in the, I also did put in the chat that link that we found that I shared with you that day, from the MyRec.
Oh, yeah.
Yeah. As well.
Yeah, awesome. Does anybody have any comments or questions or concerns or anything with regards to, the work that you do?
We're typically not a very shy group, so please, if there's a question, come off mute, and if there's anything you'd like to ask. One of the questions I am curious, I know we've seen the MyRec website before. Are those resources available to people who are not necessarily working with veterans? Because sometimes it may be hard to know, with the patient population coming into different primary care settings or health settings, we may not know until we start using more of those screeners of, have you ever served in the military? But lots of great things. So 2 questions. 1, could anyone besides people working within the VA system access the resources on MyRec? And then 2, well, I guess that's the question.
Yeah, so these, and Julie, please feel free to chime in, but yeah, so any of our public facing materials are available to community providers, and that's so much a part of the work. The suicide, there is even a suicide risk management program through the Rocky Mountain MyRec that is for just even people in community who are working with veterans and how to help them conceptualize risk and risk mitigation strategies. So they really do have that available to community. And I would say too, a lot of, so it's not just for within the VA system. And I also we are specifically talking about veterans here today. A lot of these skills, though, are transferable, and I think is kind of worth the time to kind of look through these materials. The SAVE training, right, specific to veterans, but I think most people want to be validated and treated with respect and, ask direct questions and things like that. So I think it behooves all of us to, get this information specific to our veterans, but it's definitely something that, we can also use just in our work, I think.
Mm-hmm. Other questions?
I see some hospital folks on here and different kind of various settings. And I was just wondering, what tools are y'all using now to connect someone to care if that comes up, if they're a veteran or, eligible to receive services at VA, or if they have a question, kind of what's kind of the baseline for the group, I guess, as what we're already using or kind of what's in place. And I know we have folks from 2 different VA catchment areas, so you may have different points of contact or things like that. But I was just wondering how we can be helpful. Oh, Barbara said, I volunteer with my local Quilt of Valor group. We have had multiple veterans tell us that the quilt they received gave them purpose and community. That's really beautiful, Barbara. Thanks for
That's nice.
that work that you do.
And I think piggybacking on that, Kate, the question to the group was, how are we identifying veterans and then connecting them to services? But any tips on really what should be happening in primary care and in hospitals and health systems? Should there be a screening question? Should we be asking every person, have you or a family member served in the military? Because my guess is, if not, sometimes people don't volunteer that information. They may not be aware that they could be
Mhm.
eligible for all of the services that you all are offering. That's something I've found when working with people.
Yeah, absolutely. I think, like what I shared about my father-in-law, I don't think that he would just tell you that, you know?
Yeah.
Um, and so uh, recently, there's been an expansion of eligibility through like the PACT Act. Um, there's different, I just learned a few months ago that if somebody has, I think it's a Native American, like a tribal registration card, some of their copays are waived, right? I didn't know that. So I just, so there's so many um, different avenues for care that I do think if we're not asking, we are kind of taking that off the table, right? Before we even know it's an option. Um, and there's really good work being done in community veterans who do get care through VA, especially some of our trauma recovery programs, our peer support services. These are really specific for folks who've, you know, uh, been in service and tailored to them. So we giving them that opportunity to get that care or to find out if they're eligible, I think would really kind of go a long way just in their own treatment. I don't know, Julie, if you have anything to add to that.
Yeah, I think there's a lot, there's just a lot of different resources that people aren't, I mean, even myself, and I've been with the VA for 15 years, I'm like, oh, how come I didn't even know about that? As a matter of fact, I'm looking through these slides and I'm like, there's a program called Coaching into Care, which is for family members of, you know, veterans, if they're seeking family members and friends who are seeking care services for a veteran. And I'm not sure I really knew about that. So yeah, there are tons and tons of resources out there. It's just a matter of, you know, having the information about them.
Yes, connecting them. I know we're almost at the top of the hour.
Yeah.
So I think a huge takeaway today is it's important for us working out in the community to be able to identify people who have served in the military, get them connected with the VA, and knowing the VA has such a vast array of services. Even people working there for years are finding out all of these amazing services. I do have to say, I've looked multiple times at different suicide prevention programs, lethal means programs that's been public facing. Phenomenal resources out for just the community, as well as you all have an amazing integrated behavioral health program. And all of these programs are so needed and available to people who have served in the military. So thank you all for sharing with us, for taking the time this morning. We know it's early, um, and connecting us with all of these resources, because we'll be getting these out. If you want to send us the PDF that you showed us of the trifold, we could send that brochure to our attendees this morning. And then if people are interested, they could reach out to you if they want a specific hard copy.
Yeah, absolutely. And there's also, Kate put in the chat, I think, the Veterans Guide discussing secure storage, and all of the PDFs are there, but I certainly don't mind to send you that specific PDF if that's easier for you.
Sure.
Kim.
That'd be great. Thank you.
You're welcome. Thank you guys.
And thank you again for all of your time. And I know, and I don't know if you want to advertise this now, but I think you're having a community suicide training sometime in September. And so if you wanted to mention that, you might get attending
Yes.
in the community.
Thank you, Kim. Yes, I have to be.
No worries. This is what I'm here for.
Yeah, we are. And I will send the flyer because we had a QR hiccup code, whatever. And so I'll send the flyer with the registration. So I'd mentioned intimate partner violence and suicide prevention at our VA work so closely together. We are putting on a joint conference September 30th. I believe there's 5.5 hours of free CEUs available. And it is, thank you, Julie. Yes. And it's, we're going to be hosting it at Crystal Bridges.
Oh,
I know. Yeah. So it'll be at Crystal Bridges up in Bentonville. I believe there's a virtual option for that. I'll send the flyer. And so that's something that we're just going to have a host of VA and also community presenters kind of sharing on these two topics, how they intertwine, and the work that we're doing in VA, and also kind of highlighting some of the community work as well.
awesome. Well, please, yeah, get us the flyer and we'll advertise this. It's exciting, and I really appreciate you guys and all this important work that you're doing to help the veterans all across
Yeah.
Arkansas and the Ozarks.
My pleasure. Yeah, medical social work is very close to my heart, and this is where you're going to see so many folks who might not reach out to counseling, and it's so important, all the work y'all are doing, and this is where we're going to reach people as well. So always a pleasure to meet with you guys.
Oh, thank you, Kate. Thank you, Julie.
Thank you so much.
You're
Have a
welcome.
great
Bye-bye.
day.